Hi, everyone, and Happy New Year. I'm Laurie Hutchison. I'm the Executive Director of the Lobular Breast Cancer Alliance and a 4-year survivor of lobular breast cancer. And I'm very happy to welcome you all to LBCA's first Advocate Chat session of the new year. This is going to be an interactive discussion about important lobular breast cancer research presented in San Antonio last month. And the way we're going to be running today's program is a bit informal. In the first half of the hour, we'll be hearing from Dr. Jason Mouabbi about a few key posters depicting lobular research that he felt it would be great to highlight. And after each one that he discusses, we'll open it to a few questions. And we sent him several posters. I think he may have picked 3 that he's going to focus on. But if we only get through even 1 or 2 of them in the first half hour, that's totally fine. So after we hear from Jason in terms of the presentation of the posters, we'll then hear briefly from 2 of LBCA's Patient Advocate Advisory Board members, Julia Levine and Ann Camden, about some of their important takeaways as patient advocates attending SABCS22 in person. And after they talk briefly, we should have time for more questions. And then I know some of you had sent questions in, and we'll try to address some of those as well. Dr. Jason Mouabbi is Assistant Professor of Oncology in the Department of Breast Medical Oncology at the University of Texas MD Anderson Cancer Center in Houston, Texas. We are also very fortunate that he is a rock star member of LBCA's Scientific Advisory Board. Dr. Mouabbi has a research interest focused on highlighting the differences between invasive lobular carcinoma, ILC, and invasive ductal carcinoma, IDC, and he works to understand the ILC tumor microenvironment at the cellular, molecular, and genetic levels to identify promising therapeutics that can be studied in clinical trials to help advance the care of people with ILC. Thank you so much for joining us today to talk about some key research on lobular breast cancer that was presented in poster sessions during the December San Antonio Breast Cancer Consortium. And now, Jason, I'm going to turn it over to you, and I'm going to stop sharing and let you share your screen and take us away.
Sure. Thank you, Laurie, for this very generous introduction. I'm very happy to be here. I'm very happy to be part of the lobular breast cancer group, so part of the LBCA. I truly believe that in our lifetime, we're going to make lobular cancer history. We're starting to understand it a lot more. We're starting to study it more at the genetic, molecular, transcriptomic, and tumor microenvironment level. We've been identifying a lot of interesting stuff. Some stuff we can share, some stuff we cannot share yet, but definitely a lot of clinical trial will be initiated specifically for lobular breast cancer in the near future. I was telling Laurie right before we started that I have a few projects in the pipeline that hopefully can be started very soon, specifically for ILC patients, some in the early setting and some in the metastatic setting. And this San Antonio, we saw a big uptake of lobular specific research, which was very exciting to see. I'm hoping with every meeting, we're going to see a lot more lobular research being presented. And next is ASCO, and after that, next San Antonio. We are also pushing for a special session for lobular cancer, not a sub-session, but a whole session dedicated for lobular. It's time, and we have the right people that are pushing for it at this point. So for today, let me just share my screen. Can you all see my screen? Can you see my screen before I start? Laurie?
Yes, yes,
all
yes.
Right, perfect.
Thank you. Sorry.
All right. So the first study I want to talk about is something we did at MD Anderson, and it's looking at the biology and clinical course of lobular cancer. And this is in metastatic breast cancer. So this metastatic ILC, just I know the title did not include that, but here we're looking at metastatic ILC. It was led by Dr. Akshara, and she is, by the way, she's always on my studies because she's the one that is responsible of our database. So she helped maintain the database and run queries on the database. Roland Bassett is our principal biostatistician on all my lobular cancer cases. So he's the principal biostat, and me, Dr. Lima, and Dr. Tripathi. So here we wanted, again, part of what I'm trying to do right now in our database is to really understand the differences between lobular breast cancer and invasive ductal carcinoma, the more common type. Those studies are really needed because once we start talking about initiating studies specific for ILC, companies always ask us, well, how are they different? So it's really important to delineate the differences between IDC and ILC, early setting, metastatic setting, just so when we speak to those companies, we have something to base our prospective studies on. So as you can see, we identify a big number of patients. We had around 1,200 ILCs, around 7,500 IDCs in the metastatic breast cancer. And if we look specifically at ILCs, we find that usually ILCs occur at a later age of onset. There is fewer metastatic sites. Now, this I would take with a little bit of a grain of salt because remember that the imaging modalities we have nowadays are not optimal for lobular cancer. Still, like we're using mainly CT, chest, abdomen, pelvis, CT scans, and FDG PET, which are not ideal for lobular. I think when we start doing the FES PET more in the clinics, we will start seeing we identify more metastatic sites. But here on the conventional imaging, we found fewer metastatic sites. And patients with ILC tend to have more of a family history of breast cancer. Now, as we know, we reported here that lobular cancer tend to be less likely HER2 positive and tend to have less proliferation index, which is Ki-67. So that tells us how aggressively the tumor is dividing. Usually, lobular cancer tend to have a lower proliferation rate and lower nuclear plate. When we look at in terms of overall survival in the patient with the metastatic ILC versus IDC, we find that the ILC patient do better than the IDC patient. And this is in contrast with the early stage setting, right? In the early stage setting, we see that when you compare ductal and lobular, the first 10 years, they seem to be, the lobular do a little bit better than ductal, but after 10 years, there's an inflection point where the lobular starts having more recurrences than ductal. At least at a median follow-up or around 5 years, we find that lobular cancers, metastatic lobular cancer patients do better than metastatic invasive ductal carcinoma. And if you look at the patient with de novo metastatic disease, also they do better than IDC. Now, what's very interesting here is to look at the size of metastatic involvement. We see that ILC tend to occur more, metastasize more to the bone. And these are metastatic sites of involvement, not the first mets, I mean, in general, looking at all metastatic sites. So we see more bone and lobular. We see more skin, more leptomeningeal disease. So the contrast is very important. When we say brain mets, we're talking about lesions in the parenchyma of the brain. So this is more, IDC has more of that than lobular. But when we look at LMD, meaning involvement of the cerebrospinal fluid and the meninges and stuff like that, lobular has more of that. Similarly, we see when we talk about bone marrow, there is more lobular involvement of bone marrow, peritoneum, uterus, and orbit. So that's why we always say that lobular cancer has a peculiar way of metastasizing. It's because it goes to a little bit of different, it has a propensity to go to different areas than ductal carcinoma. But the good thing here from this study, so the aim was to really look at the differences between IDC and ILC in the metastatic settings. The results of the study show that the sites of metastatic disease are different, but in terms of the prognostic outcomes, like overall survival, lobular cancer tended to do a little bit better than ductal carcinoma. Now, I know this is just an abstract. On the publication, we're going to have more data available and statistical significance and stuff like that, but we wanted to just get this out there at San Antonio, but we're going to talk a lot more in the manuscript about those findings. All right, so I would, if you have questions about this abstract, please let me know.
Before we open it to other questions, can you just tell us what session this was and whether this is one of the ones that we have your poster online, because we're going to be sharing this information in a big story. We have
I'll get you. I don't have it on top of my mind, but I will send it to you for sure.
Yeah, I see some people taking pictures of it, so.
Yeah, no, definitely. I'll send you a high resolution.
That would be great.
PDF
Yeah,
file.
yeah, PDF would be great. Okay, thank you.
I'll do that.
And I guess I do want to ask one question to get us started, and that is, this is a big time period. And when you're talking about overall survival information, I'm wondering, in between 1997 and 2020, there were new treatments introduced and different, and I just know, I wonder if you can comment on maybe some of the challenges of doing a big retrospective looking back so long, and what that does to your findings or your conclusions from them.
Yeah, no, you are definitely right. So the treatment landscape changed for hormone positive breast cancer from 1997 to today. This is where the study was looking for. So yes, so definitely looking, and that's something we're waiting, because it's going to be a peer reviewed, right? So we're looking maybe do at different intervals, look at the outcomes at different intervals, like let's say before the 2000s, 2000 to 2010, and then 2010 and after, because the treatment were different between each of those decades. So definitely that's something we can look for. And I would anticipate, because we know that breast cancer outcomes improved with each decade going forward. So I believe the same thing we're going to find true for lobular, given that we have better treatment. We know those treatment work for lobular. This is one of the papers that was just published but presented at ASCO, where we looked at endocrine therapy plus targeted therapies, and we found that they do work on lobular as good as how they work on doctor patients. So this is something that we have proof for our lobular patient that they do work, those drugs work. So I anticipate, like you said, with time, the outcomes have been improving. But yes, here they were not stratified by that.
Okay, so I see 3 hands up and there's some questions in the chat. I'm going to start with Deborah DeGraw.
Yeah, hi. Thank you for your time today. My question is about scanning. You mentioned FES obviously is the best for lobular, and I have had 2 of those. But I wondered, other than that, because you can't get them all the time or people don't have access to them, what would you say is the best screening method for lobular, since it's so darn sneaky? Is it a CT? Is it an MRI combined with a bone scan? What is it that would be the best scanning method for lobular?
Yeah, no, that's an excellent question. I would say none of them are ideal, and we know that from the studies published when they compared them to the FES PET. Yes, those imaging were not done, and like when they approved those imaging for breast cancer, lobular patients were not in their mind, right? They were looking at the more common ductal type. But yes, they're not ideal, and I can tell you this is my struggle. Like right now, I would say 90% of my practice is lobular, so I see the frustration. It's very, very, very frustrating, to tell you the truth. When FES PET is not approved for my patient, when I have to do a CT scan or an FDG PET. So I would tell you the CT with contrast is better. And the way, if I do an FDG PET, I always do an FDG PET CT with contrast. So I get the CT contrast, basically, part of my FDG. I can tell you it doesn't pick up very well. Now, there is a very exciting news is that we have another imaging modality that's very exciting for lobular. It's PSMA PET. So as I don't know if you heard about PSMA, but PSMA is done in prostate cancer. So PSMA is a specific molecule that usually is produced by some type of cancers, mainly prostate, but we found that lobular do produce it as well. So PSMA PET is another thing that currently we have a small study at MD Anderson looking at invasive lobular carcinoma. doing a PSMA PET, and you do see some uptake. So this is something also exciting coming, and this does not depend on the estrogen receptor being there. The issue about FES PET is if you give patients a selective estrogen receptor degrader, then the FES PET is not really useful anymore because the estrogen receptor is degraded. So there is nothing for the radioisotope to bind to, whereas the PSMA PET will work regardless of the therapy you're on because you're not targeting that specific receptor or protein that you're looking for. So we have stuff coming in the pipeline. FES PET is the most ready for prime time. PSMA will be next, in my opinion, but we have a few things. Right now, there is no ideal imaging, unfortunately, but we are going to change this paradigm.
Okay, next question from the chat. If ILC is more likely to have a family history, are the other family members also lobular or DCIS? And are you looking at that?
Yeah, no, that's an excellent question. It does not really, no, it does not matter. So we find that some people had family history of ductal and they have lobular. It really does not have to be lobular before. Now, the one that are lobular in the family are the one with the CDH1 mutation, but those are more easily identifiable because somebody in the family must have a history of stomach cancer or gastric cancer, and those usually happen very early onset, and it has 100% penetrance. So people with CDH1 mutation will get gastric cancer at some point in their 20s. That's why people with CDH1 mutation in the families, what they do is they do a prophylactic gastrectomy early on in life, right? So because there is 100% penetrance of this cancer. Now, in patients with CDH1, and we included in our comprehensive review that was published last March, we found that it's about 50% ILC, but 100% penetrance for gastric cancer.
Great. Now, Julia, you've had your hand up.
Yes. Hi, Dr. Mouabbi.
Hi, Julia.
Hi. So I just had a question about the graph on the metastatic sites of involvement. So you have, and that's why I had to take a picture so I could blow it up. So you have visceral and bone and then non-visceral. So my first question is, what is included in the non-visceral mets?
Yeah, so these are the lymph nodes. Yeah, so lymph nodes, basically. That's why usually when we say non-visceral, you would think about bone only, right? But non-visceral also include lymph nodes. So that's why it was queued over here. But like separated bone and non-visceral, so basically the non-visceral here include like lymphoid tissue.
So it would be just distant lymph nodes, metastatic lymph nodes.
Yeah, distant lymph nodes, yeah.
Okay, and then the other one is for peritoneum, does that include all GI metastasis or all abdominal mets as well?
No. Here we're specific. These are patients with these are sites with peritoneal carcinomatosis, right? The lining of the abdomen.
So were there GI metastasis patients here who have GI?
Yes, there is, and those were included in the visceral. So the liver, lung, stuff like that were like colon, stuff like were included in the visceral.
In the visceral.
The peritoneum was specifically when we label in the chart peritoneal carcinomatosis. That's what we meant by peritoneum.
I got it. And then for uterus, does that include bladder as well, or is that
no? That was specific endometrial. Yes.
So would bladder? Were there any bladder?
Yeah. So bladder were grouped all with visceral.
I see. And then my last question is the second one, the one between uterus and orbit. What is that?
Unknown.
Oh.
We always say we're not gonna do medical jargon, and I swear to God, they keep slipping here and there.
Okay, thank you.
I'm going to give you two from the chat in a row,
Sure.
which you might be able to address together. They're different. Your forest plot for PFS indicates a grade 3 lobular is a lesser risk than a grade 3 ductal. Is there an explanation for that? And then second question, in recurrent cases, was PFS dated from initial diagnosis of primary cancer or from date of diagnosis of metastatic?
The what? Can you just repeat the beginning of the question? The overall survival?
In recurrent cases, was
Okay.
PFS?
Yes. Yeah. So PFS was from the metastatic. So when you diagnose metastatic involvement, basically, that's what they meant by PFS. And this is median PFS. So we don't look at the line of therapy and what the patient received. We just, again, this is not ideal because there is a lot of bias over here. We're not stratifying by the type of metastatic disease, how far in the disease course we are catching our patient in our database. This is just taking a snapshot and showing that the PFS for ductal and for lobular seem to be the same. This forest plot, honestly, it was really hard to put it back because as you can, I was against this forest plot to be put because as you can see, all of them, almost all will cross the 1, right? So they're not statistically significant. Obviously, the grade 2, you see over here that the hazard ratio is favoring more IDCs. Now, the grade 3, again, it crosses 1 and it has very wide, confidence interval, right? Like, so a lot of standard deviation happening. So it's very hard to say that grade 3 patients do better in ILC than IDC just because it crosses the 1. So it's not statistically significant. But you can definitely tell that the de novo patient, for example, ILC do better than IDC. You can tell that here if the patient are HER2 negative, the ILCs tend to do better than IDCs because those do not cross the significant threshold, which is 1, right? So anything that overlaps with 1 means it's not statistically significant.
Well, thank you. I'm going to let you move on to the next one, and we really look forward to seeing the manuscript from this.
Yes,
this is really
definitely.
great. And
it's going to be much more comprehensive.
We probably need 5 hours for each poster, but.
All right, so we're going to go a little bit more quickly. So here, this is a very interesting poster that looks at the prevalence and prognosis of ER loss in advanced invasive lobular carcinoma. And this is important. Why? Because first they looked at the CARIS database, which is a database that contains a lot of patients from everybody that used CARIS, basically. We know that ER loss is reported in literature that ER loss, and again, not stratified by lobular versus ductal, that's about 15%. So that means patient in the future might lose their ER expression and become ER negative. This study tried to see what's the true rate between lobular versus ductal, number 1. Number 2, it looked at the prognosis and what we can tell about what's happening. So they found that in lobular, the frequency of ER loss is less than ductal. So ductal is about 20%, and lobular is about 11%. So almost half of that is seen in ductal, which is good because we know that losing the ER is not a good thing, the ER expression. So if you look at the overall survival in patients with ILC with or without ER expression, so definitely the patient with ER, so without ER loss, that means they do express the ER. This is the red line over here. They do better than the patient who loses their ER expression. And this is something we already know, and this is just to reiterate that. Now, what's interesting is that if you look at the ER loss by histological type, so patient with IDC that lose their ER expression and patient with ILC that lose their ER expression, the patient with ILC, if they lose their ER, do worse than IDC when they lose their ER expression, which is really puzzling. Why is that? We don't know, but this is very intriguing, and this is statistically significant. So lobular patient, when they lose their ER expression, they do worse than IDC when they lose their ER expression. So they try to answer it a little bit, but I don't think we really got the answer. They try to see that once ILC lose their estrogen receptor expression, how can we look at what's different between the patient who responds to subsequent therapy versus the non-responder? And I'm going to focus on the genomic differences here. So we found that patients who respond, who have lobular cancer and they lose their ER expression and they still respond to subsequent therapies, tend to have more PD-L1 expression positivity, more HER2 positivity, and more HER2 amplification. whereas non-responders tend to have more this TFEB amplification and MYB amplification, which is those are transcription factors, basically. This is intriguing, but what I would wanted them to add here is the androgen receptor, right? We know that, and that's why I want to talk about this slide here. We know that almost all lobular tumors do express the androgen receptor. We know even further that triple negative lobular cancer almost universally express androgen receptor. That's why they're labeled as luminal AR, so luminal androgen receptor. So here it will be interesting to see those that lose their ER expression. What is the expression of their androgen receptor? Because there might still be luminal, and we might be able to salvage those patients if we treat them with one of those new drugs that we have that called the SARM, selective androgen receptor modulator, called enobosarm. We have a study right now available at MD Anderson with me as the PI on that study. Now this one, we're not saying it has to be lobular. We're accepting both lobular and ductal. But the reason I want to open the study, because I know a lot of my lobular patients will qualify for the study because they have the androgen receptor. So this is something that this poster did not look at. Do they still express the androgen receptor? And if yes, then I think we can really, this poor outcome, it can be salvaged by giving the appropriate therapy. So that's why this one was interesting for me.
That's great. Thank you. Any questions? I don't see any hands, nothing in the chat, and maybe we should let you go on to the next poster. And if people have questions about either.
Sure. And please, I forgot to tell you the story. If you, if anybody is interested in the study, we have, we are enrolling patients second line plus, so it's a very good option. All right. The third one is also something very interesting. It was done by the lab of Dr. Camden at UT Southwestern, and the first author is Dr. Bennett. And this is digital spatial profiling of invasive lobular breast cancer. Again, the title is very broad. I think they could have done the title a little better, because here they're specifically looking at stratification per the glucocorticoid receptor. So glucocorticoid receptor positive versus negative. The reason I like this, because digital spatial profiling, I'm just going to explain it real briefly. So this is a novel way at looking into stuff. So basically they look at areas in the tumor or around the tumor, and they can look at two things. They can look at expression, basically RNA expression. So that's the expression of genes. Because in order to go from a gene to a protein, you need to pass by an intermediary phase called the RNA. So the RNA really reflect on what is being really expressed from the genomic landscape. The other thing you can do is you can look at the protein expression as well. By looking at that, you can have insight about the tumor microenvironment, because there is some protein and some RNA expression that are specific to some type of cells, and other specific to other types of cells. So you can really have an understanding of what's going on at the tumor microenvironment level. So not only at the tumor, but also its environment. How is it interacting with the cell around it? And again, in this study, they really looked at this glucocorticoid receptor. And so they have two sets of patients. They had those sets of patients that had positive glucocorticoid receptor. They had the patient who were glucocorticoid receptor negative, and they had the patient who had mixed. So they have both areas in the tumor that were positive and areas that were negative. This is interesting. Why? Because the glucocorticoid receptor is an emerging receptor that we are trying to understand more and more, because it is being expressed in some breast cancer and not in others. And lobular breast cancer is an ideal tumor to study it on, because you really can see either very strongly positivity, or you can see negative, absolute negativity. Very few cases that are mixed. The glucocorticoid receptor, from its name, it's a receptor of the glucocorticoid, which is basically the stress hormone of the body. So cortisol and its derivatives, basically, these are the receptors for those molecules. So what they found, interestingly, is that in lobular cancer, patients who have a glucocorticoid receptor positive, they have a tumor microenvironment that is repressive for immune system. So those type of cancers, the immune system is not able to recognize the cancer. That's why there is not a lot of immune infiltrate around it. And in fact, they have the immune suppressive. So they have cells that suppress the immunity around it, which is really intriguing. Whereas the patient who have glucocorticoid receptor negative, so they don't express the glucocorticoid receptor, those patients tend to have more immune cells around it ready to attack and kill the cancer. So that's very interesting. This is something novel we didn't know about before. It's very interesting and can open a lot of doors for the future, because this era is the era of immunotherapies, right? And we know that there is a subset of lobular breast cancer patients that would benefit from immunotherapy. We still don't know who will benefit and who will not benefit. I think here we're getting some more insight. Maybe the glucocorticoid receptors that don't express will benefit. And those that are glucocorticoid receptor positive, maybe we can do something to overcome this suppressive environment and make it more of what we say, turn it from a cold to a hot microenvironment, where we can actually use immunotherapies and let the immune cells do their function, which is not only fight infection, but eliminate cancer. So this is really interesting. This is something novel, not presented before. I know that Dr. Camden's lab worked a lot on the glucocorticoid receptor. This is really interesting, very interesting.
I want to add that this is partially funded by the second ILC grant that we made through AACR, and Dr. Frerich was the PI the second year of that grant. And so more of this work happening under Linda and under Dr. Kansen is continuing. And what they said is that they've identified a drug that is already FDA approved that suppresses glucocorticoid. And so there's some really promising potential, translational research that can come next. And we're waiting to hear the second part of the research grant, which even though we had to end the grant, they're continuing the work. So we're really grateful to them for continuing to work on this, and we're excited by it. There's a question here about are GR tumors more or less likely to be ER negative? So, GR negative, so glucocorticoid negative. Can you tell?
Are they likely to be more ER positive or negative? That's the question.
Yes.
Yeah. So that's the beauty about GR. It doesn't depend on the estrogen receptor expression. So both the GR positive and negative have the same amount of ER positivity ratio to ER negative, and we know that in lobular 95% are ER positive. So they are still heterogeneous in terms of those receptor statuses. But what's really interesting is honestly is looking at the interaction with the microenvironment. It changes completely based on the glucocorticoid receptor from an immune enriched, if you want, to an immune suppressive, which is something like we always want to find one thing that can turn on or off something, right? This is ideal in medicine, and we almost never find that, right? Stuff are a lot more complex than what we think. But here it really looked like the GR expression, like it's clear cut, like the ones that are positive are immune suppressive, the ones that are negative are not immune suppressive. So that's why it's really intriguing, and it's worth doing prospective studies. So taking it from the lab to the bedside. So that's really interesting, and that's something I'm interested in pursuing further. That's why I'm working with Dr. Camden to see if we can collaborate together, try to bring what she's finding in the lab to the clinic, and go from there.
That's wonderful. Thank you. We have about 20 minutes, a little over remaining, and I wanted to give our two patient advocate advisory board members a chance to talk on some of their key takeaways from being in person for the first time in a while at San Antonio. And Julia or Anne, whoever wants to go first, just let me know. And
I can go first. My name is Julia Levine, and I'm a patient advocate, research advocate with LBCA. This was my third time in person in San Antonio, and last 2 years I did virtually. I think the third time's a charm. I mean, it is definitely easier, although there's still so much to do, so much to see that you really don't get to see everything. My key takeaways this time, I focus, since I am a metastatic de novo patient, I tend to focus when I'm at the conference a lot on that research because it's just not time to do everything, although I do see other posters. In terms of poster takeaways, I mean, I can't go into specifics of, all the posters, but there were three general, there were two poster surveys, obviously our survey on metastatic lobular patients, which I think was really important to be there because, it's really the first time that there's been any, acknowledgement, any data, even though it's not scientific data, but survey of our community of metastatic lobular patients that highlight the need for better diagnosis, imaging, and frustration and communication for metastatic lobular patients. The second survey was done by an international group, including UPMC and Lee Pei, who our founder, as you know, passed away. And that revealed gaps in knowledge also in top research areas. Then there were two rapid autopsy posters. There are two programs. One is in Belgium with KU Leuven, which is Christine Desmet, who's a friend of LBCA, a researcher there, and Karen von Balen, who was a grantee, correct? And they had a poster on the UpTiter, which is a postmortem tissue donation program. And there's also one just starting up at UPMC with Steffi Osterreich. And, these programs are important, but they're limited to a general area where these institutions are. So, you can't, not anybody can just donate their tissue. And why they're important is because what Karen von Balen and Christine Desmet found was that it highlighted that there's just a vast underestimation of disease extent on imaging when you're alive. So it's just those are important to see too, because there needs to be more of these, and there are some, I think, but these were highlighted. And then the other two posters that were about CTC, and we have them on. We have one of them that's going to be on the website, right? Lay summary of. So I don't want to go into the details, but it's using CTCs in a new way to determine better information about a person's tumor, an individual tumor. And you can read about it on our website. It's a good lay abstract. And also there was one, which I don't know if we will have, but it was about leptomeningeal metastasis and using CTCs as opposed to ctDNA, or instead of ctDNA, to diagnose leptomeningeal disease earlier. This is important, obviously, for leptomeningeal patients, and we know that, we know that lobular, there are quite a big, large percentage of lobular patients in the leptomeningeal disease category. So this is really interesting because it's a much easier test to help diagnose leptomeningeal disease rather than a ctDNA. So all of these, including, and you can cut me off when there's time, Lori, because all of this I have written up and will also be right on the website. Okay, so then in terms of, there's, exciting new drugs coming out, and they really did, there was a whole session on clinical trial updates and new drugs on the horizon for metastatic estrogen positive breast cancer. And the two that are most interesting to me are coming as soon is elacestrant, which is an oral SERD, an estrogen degrader, which hopefully has better bioavailability and can be used in place of the dreaded fulvestrant or Faslodex injections. That should be coming out, what I was hearing, like next month, maybe Dr. Mouabbi can tell me.
Yeah.
And then the other one is called capivasertib, which is an AKT inhibitor, but will target the PI3 kinase pathway. So for those who have PI3 kinase mutations, it's supposed to have less toxicity and side effects than the one that's currently approved called alpelisib or Piqray, which has just really, difficult side effects. And then the other stuff that's really interesting is on CDK4/6 resistance, because there's all kinds of trials that kind of talk about what to do after you've used a CDK4/6 already. And they're really, to me, there's like no agreement. And I think that's kind of what the session was saying. It was a year in review session. Sorry, it was a view from the trenches, what to do on Monday morning. And there's a list of different options. And, I won't go into it, but it's written down. And finally,
Sorry, go ahead.
Finally, I do have to say that I was disappointed with the amount of lobular, not the posters, but the session. There was one lobular session. It was a basic overview, has a lot of information in it. But 2 years ago, there was a whole spotlight session on lobular breast cancer, more in the basic science realm, I believe. But I do think one good thing is that it was acknowledged. It was acknowledged, I think, on Twitter by one of the organizers, and also in the year-end review, there was a slide, and it did say, and this I thought was really fantastic, that lobular should always be brought up in the year of review every year. And it talked about lobular being invisible, and there's slides that we have on that. Thank you.
That's great, Julia. And I'm going to go to Anne, and then we can open questions at the end afterwards if there's time.
Yeah, I will be brief. It was my first time attending in person. I attended virtually for the last few years as well, and it made a world of difference being there in person. And I'll probably pick up where Julia left off, that, I too was disappointed that there weren't more sessions devoted to lobular, and that the one that there was kind of basic, which is saying something, because my level of understanding is still pretty basic, even living with this since 2016. So I think what, it really drove home for me, and I'm in an area that doesn't have a lot of access to clinical trials geographically, is how important they are and how specific they need to be. You hear about them happening all the time, but it hadn't really been driven home to me, even though Lori has mentioned it many times over the last year that, we need them to be really specific to lobular. And in my case, I also want them to be specific to leptomeningeal. Those are things that are really difficult. I didn't understand how hard it is to put those clinical trials together and find a cohort that would be able to follow through with that. But I did feel like there seemed to be swelling interest, and hopefully next year more space would be dedicated to that. When I reviewed the posters, and I understand there were a record number of posters this year, and I certainly didn't understand all of them, but I always focused on the conclusions, and in nearly every conclusion, it went on to say, especially since a lot of them are retrospective or surveys, that we have got to have more clinical research that is dedicated to looking at lobular. And they used words like incomplete, unreliable, understudied. And I think it just drove home, especially as an advocate for lobular, how critical that is, so that next year when somebody's giving this report, that they've got some really great clinical trials that we would be eligible for, and continue to do the great work that is being done so that we can make a difference.
That's excellent. Thank you. Those are great points. And in fact, I'm going to ask Dr. Mouabbi just quickly to address some of the points that you and Julia have made, but in particular to talk about how we're going to really accelerate the ILC specific clinical trial creation, and in particular metastatic lobular breast cancer, because metastatic breast cancer is often, well, in the case of lobular, faces the issue of you don't have measurable disease, or it's hard to have measurable disease. So Dr. Mouabbi, if you could just say a couple of words about this, and then we'll have time for a few more questions from everybody.
Definitely, yeah. And thank you, Julia and Anne, for sharing your experience. And I can promise you, we have momentum now, and we're gonna keep pushing. There was a lot of frustrating moments, to tell you the truth. At the end of the day, to do studies, you need pharma to be involved. The money that you get from the government and from institutions is very limited. You need big money, and those come from pharma, and pharma were not biting initially. And my frustration was, I was like, I just want one pharmaceutical company to bite, and I'm gonna reel them in for Lobular. And finally, we have momentum. Finally, we spoke. I'm speaking with BMS right now. I'm speaking with AstraZeneca. They do understand Lobular after so many meetings. You know, initially I was meeting with them, talking about concepts. I stopped doing that. I just meet and talk about Lobular. I want them to understand what it means to be Lobular and what does it mean. Because, you know, they think about HER2 positive or what triple negative. I think what really drove it home is this year, the ACS, when they showed the number for triple negative, they anticipate 29,000 new cases, and they anticipate only about 40,000 HER2 positive. I told them, what ILC that you are ignoring is 44,000. They have more patients over there. So this really drove the message home for them. And I think now they are willing. I'm having 2 studies almost advanced, and that they involve specific biomarker for lobular cancer that we can target. One of them involved immunotherapy. The other one involved targeted therapy. Soon I'm going to be able to disclose more about those studies, but this is in the metastatic setting. But also we're attacking the early setting. We know that endocrine therapy works for lobular, but we can optimize it by giving something extra. And that's the extra. I think we're finding a way to nail it down as well. So there is a lot of stuff happening, a lot of exciting stuff happening. And I'm happy to say we are very close to a level to have clinical trials, like therapeutic trials, not only observational trials or trials that are not therapeutic, looking at differences and trying to just to learn more about lobular. Here we're trying to treat, cure, eradicate lobular. So we are getting there. We are working diligently. I would say I have the backing of my department to study lobular. The problem is, yeah, again, there is not enough philanthropy for lobular like we have for other type of, but we're changing that. We are changing that. We are getting involved more. We are out there. Again, we have momentum at this point, and we're gonna keep on pushing forward. I just want to point what Julia said about the capivasertib, that actually it is exciting for lobular, tell you the truth. And we have studies from both Steffi's lab at UPMC, and we have from Dr. Dursken's lab from the Netherlands, that in lobular cancer, the AKT protein is activated irrespective of mutation in the pathway. So usually when there is a mutation in the PI3 and the PIK3CA, AKT, mTOR pathway, this is one pathway. When there is mutation, it leads to overexpression, right? It leads to increased expression. Well, we find that regardless of a mutation, even if there is no mutation, the AKT is overexpressed in lobular. So having an AKT inhibitor very close for FDA approval is very exciting. And that's one of the studies I'm trying to bring to the earlier setting, because now that we know that it works in the metastatic, and I asked AstraZeneca to do a subgroup analysis, and I truly believe the lobular will benefit the most from this therapy. But also we can bring it to the early setting, right? And this is the study that right now we're in advanced stuff to open. It's going to be part of the NCI. So the NCI has a CTAP, and the drug is part of the CTAP. And so we're gonna, and I already presented my concept, and I liked it, and we are right now in the study design phase. So this is exciting for lobular, this one, especially the Capitello study. Now, if you look at the other one, the one that looked at the oral SERD, that the SERENA-2 study that looked at camizestrant, yes, so definitely it's exciting. Why? Because camizestrant is an oral SERD, and it goes along the line of the Emerald study that was they showed us a result a year ago about elacestrant. And those basically, if you want to think about them, they're oral form of fulvestrant, which is an injectable medication. The beauty about doing something oral is you can give a larger dose. The issue about fulvestrant, we are really limited with the dose we can give, because each butt cheek we can only do 250 milligrams. So a total of 500. So even if you talk to Dr. Matthew Ellis, who discovered that medication and studied it when I was with him at Baylor, he used to tell me the best way to do it is to have 4 butt cheeks, so you can give 4 injections. So you cannot do that, right? So that's why the oral medication is ideally better. Why? Because you can give more drug. So that's why we think, and you do see specifically in the ESR1 mutated patients. So a patient who have ESR1 mutation, they work really well. And that's what I think the niche will be for those drugs. Remember, all those studies look at single agent drug, and they still showed benefit. So I can only imagine when they combine them with directed therapies, I think we can really improve outcomes of lobular breast cancer patient, because one of the questions that was asked is, what is ESR1 mutation? So that's a very important question. Why? Because 95% of lobular are driven by the estrogen receptor. How is estrogen receptor activated? By estrogen binding to it. So when estrogen binds to it, it gets activated. Until now, the treatment to target the estrogen receptor is eliminating estrogen, right? What if the receptor is mutated? That means it's always turned on regardless whether estrogen is binding or not. This is the problem, right? So with time, as we're suppressing estrogen long enough, some of those cancer cells mutate themselves, right? And they don't depend on estrogen. They just reconfigure the estrogen receptor by a mutation to become turned on all the time. The only way to overcome that is to degrade the receptor, eliminate it. How can we eliminate the receptor? The only treatment right now we have is fulvestrant. So it's good to have those next generation, those oral steroids that can degrade the estrogen receptor. We also have other lines, like we have something called a Protac, we have the Ceran. Those are other ways to antagonize and degrade the estrogen receptor. We have 2 of them going to be open at MD Anderson very soon as well. So this is a new way of going, and those will overcome the ESR1 mutation, which is seen in 20 to 30% of cases. And this is how endocrine therapy becomes futile, basically. So it is an exciting time. I know next month, the elacestrant, by I think February 2, they're going to get that approval. This is when they're going to get an answer, and everybody's excited because we think that they're going to get an approval. And after that, we're going to get the other drugs. So it is an exciting time. We are getting more drugs. We are getting more effective drugs. That's what I want to clearly say. But we are also getting more stuff specific for lobular cancer.
So I want to ask you 2 questions from the chat related to this. One was a comment or question that you're doing a clinical trial for AR positive, but does that have to be people with loss of ER expression to go into that study? And do they have to come to MD Anderson to be part of the trial?
The first question is no. They don't have to be ER negative. In fact, ER positive, the study is for ER positive. The beauty about this drug, enobosarm, I'm a big believer in this drug because the preclinical data is very impressive. And it has some positive side effects. So enobosarm, because it's a partial androgen receptor agonist or modulator, what it does, it also increases lean muscle mass. So it increases the muscle mass of patients, and increase bone density. And it doesn't have none of the side effects of testosterone or steroids because it's still non-steroidal. So what it does, so it doesn't increase like the hematocrit, to bad levels. It doesn't make the body produce less cortisol. It doesn't do, or it doesn't increase facial hair in females. It does none of that because it's not testosterone, right? It doesn't follow that pathway. It's engineered a drug that only partially activates the androgen receptor, but it's activated enough to have all those positive side effects. And we know androgen receptor expression in lobular cancer is a good thing. So forever, people were trying to antagonize the androgen receptor, right? To block it like they do in prostate cancer. And we know those studies did not work at all. The patient outcome became worse than not giving those drugs. That's because what you need to do is activate that receptor, not block it. That's what's needed to turn off lobular breast cancer. And this drug, that's what it does. It turns it on a little bit. So it's second line plus patients who are ER positive do qualify. The reason I opened it, although the study was not created for lobular specifically, but because I want to enroll a lot of lobular on it, and we agreed with the company that we're going to do a subgroup analysis specific for lobular in the future.
Great. Quickly, 2 other questions for you. One is, do metastasis at different sites respond differently to a drug? such as peritoneal versus bone or lung. And then a second part to this question, based on all of your knowledge of the drugs that you have at your hands, what Lobular responds to and what's coming. The question is, how important do you think it is for patients to be treated by oncologists with Lobular expertise? I know there's no specialty yet.
Yeah, but
So-
it's very important. I'm going to start with that because it's very important. I can tell you at my institution, I struggle. Like we're talking, we do a weekly meeting where we discuss cases. And until now, I see in the middle of the meeting, like patient, I want to start tamoxifen, for example. And I keep telling them, if you have a better therapy, why don't you do the better therapy for lobular, you know? And so it is a struggle. It is important for lobular breast cancer patients to seek somebody with lobular expertise, in my opinion, because it's very unfortunate, to tell you the truth, that, and I can tell you, most people will look at lobular and ductal as the same type of cancer. And even I'm telling you, at my own institution, which is one of the best cancer centers in the US, if not the world, and I still am struggling with changing how people think about this. That's why right now we started the Lobular, the ILC working group, and basically we're drafting guidelines so everybody can have those guidelines to follow how to treat lobular, because they're still thinking about them as doctors. Surgeons do the same thing. So it is important. There is not a lot of people dedicated for lobular, but it's increasing. I can definitely tell you it's increasing. I have a lot of fellows nowadays that are very interested in becoming lobular specialists, which is something very exciting for me, right? So it is changing. We are increasing awareness. We are doing a lot of stuff like that. But yes, so that is something very important. Now, in terms of treatment responses, yes, the site depends, because at the end of the day, a lot of the drug have to reach the tumor to be able to be effective. The problem with peritoneal carcinomatosis, a lot of times those cells are not leaching anymore to any blood vessels. So it's hard for those drugs to come through. That's why endocrine therapy works really well for those patients. Why? Because here you're not attacking the tumor directly, you're reducing the hormones of the whole body or eliminating the hormones. Then what happened, there is no more gas pedals for those cancer cells to grow. So that's why those therapies are very effective for lobular cancer, regardless of the site. But once you go more to chemotherapy or more to those antibody drug conjugates, where those drugs have to reach a certain target in order to work, you see the effectiveness go down. But I can tell you that we have two ADCs, one in HER2 and one sacituzumab, and both of them work really well for lobular. So that's the exciting part, right? So there is some anecdotal cases that I have, some anecdotal cases that Dr. Otto Metzger from Dana-Farber had, but we share those, like we talk about those cases. We see patients with peritoneal carcinomatosis that have a lot of recurrent ascites because the tumor, as they grow, it brings in water. We see those patients when we treat them with HER2 or with the sacituzumab, that the ascites goes away. So they work really well. So this is something chemotherapy could not do before, but now we have two drugs that can be potentially part of the treatment course that can really improve outcomes. So this is very exciting, and that's why I'm talking to Gilead, and we're talking to AstraZeneca to study them more in lobular, right? To do small studies specific for lobular, see if what we're finding anecdotally is actually true. But they do work.
Well, this is very exciting, and we are actually a minute past the hour. So I have a question for you, Jason. There are a number of questions that we didn't get to that are in the chat box. If we send them to you, maybe we can send out answers to those questions. Some of them are further questions about your particular clinical trial. And we are going to be providing lay summaries of the posters in a story by the end of this month, including of Dr. Mouabbi's two posters. So I really am grateful to you, Dr. Mouabbi, and to Anne and to Julia for sharing your perspectives about what sounds like I'm feeling very optimistic about all that you all have shared. And I want to thank you all for joining us today and being a part of this, and thank all of you for coming, and stay tuned for the next ones we have scheduled.
Thank you all. It was a pleasure.